Welcome to the deep dive. Today, we're getting into something really, really essential, how drugs actually work in your body.
Yeah, and we're not just talking prescription meds here.
No, exactly. We mean basically any substance that interacts with you to change how things function. We're going to unpack what they are, how they get around inside you,
What they actually do when they get there.
and some really crucial things to know, to stay safe and make informed choices.
Absolutely, because this stuff touches everyone.
Yeah.
Whether it's like an over-the-counter painkiller, something your doctor prescribed,
Or even things in your diet, right?
or your environment. Yeah.
Yeah.
Understanding the basics is just so empowering. It really helps you feel more in control, helps you talk to your doctor, your pharmacist.
Have better conversations.
Exactly.
And we're using insights today from Roland Seifert's Drugs Easily Explained. So our mission for this deep dive is to pull out the really important myths, the practical stuff, maybe some surprising things too.
Give you a kind of shortcut to getting your head around this complex topic.
Okay, let's dive in. So the source starts right at the beginning, tackling this really basic but pretty deep question. What is the difference between a drug and a poison?
Right. And it immediately says, look, it's not just good versus bad. The real difference is whether the substance helps or harms the body at a specific dose.
So the dose is key.
Absolutely key. The same exact substance could be helpful as a drug or harmful as a poison. It all depends on how much you take and how it's given. Think of it like trying to restore balance.
Okay, so drugs are often about bringing things back into equilibrium, like fixing an imbalance?
Precisely. The source uses this analogy of a scale, Drugs are tools to correct a disturbed balance in how your body functions.
Okay, but then it gets really interesting right away because the source brings up the placebo effect.
Yeah.
You're saying something with literally no active chemical in it can still have a real effect.
Oh, absolutely. The source really highlights this. Taking a drug isn't just chemistry. It's a human interaction, too. The advice you get, the attention from a doctor or pharmacist, plus what you expect to happen. That combination can seriously influence the outcome,
Wow.
especially for things like pain or trouble sleeping or, digestive issues. That psychological side is powerful stuff.
And the flip side of that, the darker side, is the nocebo effect.
Yes, exactly. That's when taking something totally inactive actually causes adverse drug reactions, ADRs we call them.
So just expecting side effects can make them happen.
Pretty much. Maybe you heard warnings from your doctor or read something online. That expectation can trigger real symptoms. Fatigue, headaches, stomach upset, stuff like that. And the source specifically points out that homeopathic drugs, which have no active substance, well, they show these nocebo effects.
That really drives home the power of the mind, doesn't it? And the whole context of care.
It absolutely does. It's not just the pill. It's the whole ritual around it.
Okay, so fascinating. But even with actual drugs, the ones with active ingredients, they don't work the same for everyone. Why is there so much variation?
Yeah, that's another huge point. The source lists several really critical factors. Age is massive.
How so?
Well, newborns, infants, children, and the elderly. Their bodies just handle drugs differently. They process them, react to them in unique ways. Older people, for example, are often much more likely to experience ADRs.
Right, so less is often more for them.
Often, yeah. Minimizing the number of meds they take is generally a good idea.
What else makes a difference?
Okay, so there's your sex, your ethnicity, your diet, even things like whether you drink alcohol or smoke. All these can change how your body absorbs a drug, how it breaks it down, how it gets rid of it. And the source also mentions pregnancy. We actually have pretty limited safety data for a lot of drugs during pregnancy.
Which is why doctors are cautious.
Exactly. They tend to prefer older drugs, ones that have been around a long time and have a better understood track record, if treatment is really necessary. It's just, well, everyone's body chemistry is slightly different.
Okay, let's switch gears a bit and talk about navigating the jungle of drug names. It feels like you need a secret decoder ring sometimes.
Oh, tell me about it. It absolutely can. And the source points out the confusion often starts because most drugs have at least two names.
Where's the generic name and the brand name?
Exactly.
So what's the advantage of knowing the generic one? Why bother?
Well, it's universal. The generic name is the official sort of scientific name for the active chemical. It's recognized everywhere, all around the world.
Oh.
So if you know that name, any doctor, any pharmacist, anywhere, they know exactly what substance you're talking about. Super helpful if you're traveling, for instance.
Makes sense. And the brand names? They cause problems sometimes.
They can. For one, they're often specific to one country. So you travel somewhere else, the brand name might be totally different, which causes confusion.
Right.
But the bigger issue the source highlights is how these brand names are created. They're marketing tools designed by the drug companies.
And they can be misleading.
Sometimes, yeah. They might imply certain benefits or, a level of ease or safety that doesn't quite match up with the reality of the drug's effects or, importantly, its risks.
That sounds potentially quite dangerous. Does the source give specific examples?
It does, and they're pretty stark. It mentions Accompli, marketed for diabetes, obesity. Sounded good, right? But it got pulled because it significantly increased suicide risk, hardly complication-free.
Wow. Okay.
Then there's Bonvive for osteoporosis. Sounds like good life, but the source notes it can cause serious jaw damage. Or Champix for quitting smoking. Sounds like a champion, makes you feel good.
Yeah.
But the reality of the drug, varenicline, is often that patients don't feel great on it.
So the name suggests something the drug doesn't deliver.
Exactly. And one more, Halcyon. Implied happiness, tranquility, but it hid real risks of addiction and withdrawal problems. These names can really gloss over some serious downsides.
Those examples are powerful. Okay, what about biosimilars? Are they like generics, but for those really complex biological drugs?
That's a perfect way to put it, yes. Biosimilars are shown to be comparable in effectiveness to the original, often incredibly expensive biological drugs. The source points out they offer major cost savings.
Even if the original makers argue otherwise.
Yeah, sometimes the original manufacturers might try to downplay how similar they are, but the science generally supports their comparability, and the potential for savings is huge.
The source also flags issues with some of the old drug class names, saying they're not very accurate now.
Yes, this is a really interesting point. It's because a lot of older drug categories were named based on what they were first used for their indication, often before we really understood how they worked at a molecular level.
Okay.
So now, with better understanding of the mechanisms, we know many of these drugs do a lot more or are used for many more things than their old names suggest.
Like anti-epileptics.
Right. That name makes you think only for epilepsy. But those drugs are used for nerve pain, mood stabilization, all sorts of things now. Same with antipsychotics. They're widely used for depression, too. The old names just don't capture the reality anymore.
And the NSAI example really hits this home, doesn't it?
It really does. NSAID, non-steroidal anti-inflammatory drug. Now, that name sounds deliberately chosen, right, to distinguish them from steroidal drugs like glucocorticoids or cortisone.
Which had a bad reputation for side effects.
Exactly. So non-steroidal kind of implies safer, maybe even harmless, but the source is really strong on this. NSAIDs also have serious long-term adverse effects. Kidney problems, stomach ulcers, high blood pressure.
So a better name would be based on how they work.
Yes, a more neutral mechanism-based name is cyclooxygenase inhibitors because that's the enzyme they block. Doesn't sound inherently safe or unsafe, just describes what it does.
And the danger is, because NSAI sounds okay, and drugs like ibuprofen are just on the shelf.
People might think, oh, it's fine, and take them regularly for chronic pain without talking to a doctor or pharmacist.
And that significantly increases their risk of those serious problems you mentioned.
Precisely. The name itself, plus the easy access, can unintentionally lead to misuse and harm that could have been avoided.
Okay, let's trace the journey. How does a drug get from an idea in a lab into, our hands? What's that development process look like?
Well, it's a pretty long and rigorous road, according to the source. Starts with preclinical stuff, lab studies, maybe animal tests.
Right.
Then you get into the human trials, the clinical phases. There are usually three. Phase 1. Small group, often healthy people. You're looking at safety, how the body handles the drug, absorbs it, breaks it down, gets rid of it, and catching early side effects, those ADRs.
Okay, phase 1, safety.
Phase 2 moves into a small group of patients who actually have the condition the drug is meant to treat. Here, you're starting to look at efficacy. Does it seem to work? What are the right doses?
And phase 3.
That's the big one. Large numbers of patients, often comparing the new drug against existing treatments or a placebo. You need enough data here to convince regulators like the FDA or EMA that the drug is safe and effective enough to be approved.
But the source points out that even after approval, the story isn't over. Real-world experience can be different from the trials.
Yeah, this is a really critical point. Clinical trials are controlled, very specific patients, often monitored super closely. Once a drug is out in the wild, used by a much broader, more diverse population.
Things can show up that weren't obvious before.
Exactly. Unexpected side effects, or maybe it doesn't work quite as well in certain groups, or issues with how people actually take it. The source used those NOACs, the newer blood thinners like rivaroxaban, as an example.
How so?
Well, they worked great in trials. But in the real world, their effectiveness really depends on people remembering to take them every single day. They wear off fast, miss a dose, and that protection against clots can drop quickly. That wasn't as apparent in the structured trial setting.
So we, the patients, actually play a role even after a drug is approved.
A huge role. If you're on a new drug, reporting any weird symptoms or side effects you suspect might be linked to it back to your doctor is vital. That real-world feedback is crucial for building up the full picture of a drug's safety over time. Trials just can't catch everything.
The source mentions company studies too.
It does mention that pharmaceutical companies do observational studies after approval, but also sort of flags the potential for financial conflicts of interest there, which is worth keeping in mind.
Okay, I've heard people talk about drug repurposing. Is that like teaching an old drug new tricks?
That's a great way to put it, yes. And the source highlights it as a really promising approach. You take a drug that's already approved for one thing, already has a known safety profile, known side effects, known interactions.
And you see if it works for something else.
Exactly. Because you already have all that existing knowledge, the development process can be much faster, potentially safer, and cheaper than starting completely from scratch.
Any examples?
Yeah, the source gives metformin. It's been a go-to diabetes drug for ages. But it was found to be helpful for polycystic ovary syndrome too. And it even played a big role treating COVID-19 during the pandemic.
That's pretty clever, leveraging what we already know. Now, the source also gives a pretty strong warning about where you get your drugs.
Oh, this is super important. A big red flag about buying drugs from unknown places, maybe abroad somewhere, or sketchy websites online.
Why? Risk of fakes.
Fakes are a huge risk, yeah. You don't know what you're actually getting.
Yeah.
But also, even if it's the real drug, you might misuse it, like taking way too many harmless painkillers because maybe there was some misleading discount, like buy one, get one free. That can lead to really severe side effects.
So stick to proper pharmacies.
Absolutely. Never buy from obscure sources. It's just not worth the risk.
And related to getting drugs, the source brings up shortages. We've heard about those recently.
We have. It's a real problem. The source links it partly to how drug production got super optimized, often concentrated overseas.
Which can lead to problems.
Unfortunately, yeah. Sometimes quality control issues, like contamination. It mentions valsartan and ranitidine recalls due to carcinogenic impurities. That obviously causes recalls, shortages, and a lot of uncertainty for patients who rely on those meds.
What's the proposed solution?
The source argues for having more regional production of essential drugs, kind of spreading the risk, and maybe even national reserves of key medications. It makes the point that actually a lot of common diseases could probably be treated with a core list of maybe 100 or so drugs.
Interesting. Okay, let's zoom right inside the body now. The source talks about the key targets where drugs actually do their work. What does that cellular machinery look like?
Right. Think of your cells having all these different components, like little machines or communication ports. The source simplifies the main drug targets into about 5 types. You've got receptors.
Like docking stations.
Exactly, like specific locks on the cell surface or inside. Drugs can act like keys. Some unlock the receptor and activate a process. Those are called agonists. Others block the lock so the body's natural key can't get in. Those are antagonists.
Okay, receptors. What else?
Then you have enzymes. These are proteins that speed up chemical reactions in the body. Lots of drugs work by inhibiting specific enzymes, slowing down a particular process.
Got it.
Then there are pumps, which physically move substances across cell membranes. Drugs can block these pumps. And channels, which are like gates controlling the flow of ions, charged particles like sodium or calcium, into or out of cells. Drugs can block these channels too.
And the last one?
The cell nucleus itself, where your DNA is. Some drugs, especially things like cancer chemotherapy agents, cytostatics, target processes right inside the nucleus to affect cell growth or division.
So basically, drugs hijack or modify the function of these specific cellular parts.
That's a good way to think about it.
Yeah.
By interacting with these targets, they change what the cell is doing, hopefully in a way that corrects that imbalance we talked about earlier.
Now, what about drugs that hit more than one target? The source says that can be good or bad.
It really depends, yeah. A double-edged sword, sometimes. Sometimes hitting multiple targets is actually the goal.
Like when?
The source gives the example of antipsychotics for schizophrenia. Schizophrenia is complex, involves multiple neurotransmitter systems. So drugs that act on several different receptor types might actually be better at counteracting all the different aspects of the disorder.
Okay, so that's the good side. When is hitting multiple targets a problem?
It's a problem when hitting those other targets causes unwanted side effects. The classic example given is non-selective beta blockers, like propranolol.
Used for heart conditions.
Right. Primarily, you want to block beta-1 receptors, which are mostly in the heart. That's the desired effect. But propranolol also blocks beta-2 receptors.
And where are those?
Lungs, blood vessels.
Mhm.
So blocking beta-2 can cause problems like triggering asthma attacks in susceptible people, giving you cold fingers, or, and this is dangerous, masking the warning signs of low blood sugar if you have diabetes.
Ah, I see. So selective drugs were developed to avoid that.
Exactly. Selective beta-1 blockers were designed to hit just the heart target and avoid those beta-2 related side effects. It shows how understanding targets helps refine drug design.
So it sounds like often the side effects, the ADRs, are actually directly linked to the drug's main way of working.
Very often, yes. They're not always random. They're frequently just the drug doing its job in the wrong place or affecting a related system. The source uses methylphenidate as another example.
The ADHD medication.
Yeah. It works by boosting certain neurotransmitters in the brain to improve focus and attention. That's the goal. But those same neurotransmitters also affect blood pressure and appetite control.
So side effects like increased blood pressure and decreased appetite are kind of baked into how it works?
Pretty much, they're direct consequences of that mechanism. The source also mentions that needing medication breaks from methylphenidate can be way because it actually depletes the brain's stores of those neurotransmitters, and they need time to build back up.
Okay, we've talked about what drugs do. How do they get to those targets after you, say, swallow a pill?
Right, oral route is most common. So you
Yeah.
swallow it, it goes down to your stomach, then mostly into the small intestine. That's where most absorption into the bloodstream happens.
And then it travels around.
Yeah, the bloodstream carries it throughout the body. Now, if a drug needs to work on the brain, it has a special hurdle, the blood-brain barrier.
A protective layer.
Exactly. It's very selective about what gets through. Generally, drugs that cross it easily need to be fat-soluble, small, and not have an electrical charge. The source uses ethanol alcohol as a familiar example.
Because it affects your brain quickly.
Right. It crosses that barrier very easily.
How long does a drug stick around? How long does the effect last?
That depends heavily on its half-life. That's the time it takes for your body to eliminate half of the drug that was absorbed, usually through the liver breaking it down or the kidneys filtering it out.
And half-lives vary a lot.
Hugely. The source gives examples. Glycerol trinitrate for chest pain has a half-life of just minutes. Very short action. Bisphosphonates for osteoporosis. Half-lives measured in years. They stick around for a very long time.
Wow. Any others?
Amiodarone, a heart rhythm drug, is mentioned as having a particularly tricky, long half-life. It can build up in the body, and side effects can pop up even months after you stop taking it. Makes it complex to manage.
With all that variation, can doctors actually measure the drug levels in your body to help get the dose right?
Yes, absolutely. For certain drugs, especially those where the effective dose is quite close to a toxic dose, a narrow therapeutic window, we call it, they use therapeutic drug monitoring, or TDM.
How does that work?
It usually involves taking a blood sample and measuring the concentration of the drug. It helps the doctor find that sweet spot enough drug to work, but not so much that it causes bad side effects.
What kind of drugs need TDM?
The source mentions lithium, used for bipolar disorder, and some anti-epileptic drugs as common examples where TDM is really helpful for tailoring the dose.
And can TDM also show if someone isn't actually taking their medication?
It can, yes. If the blood level comes back way lower than expected for the prescribed dose, it might suggest the patient isn't taking it consistently or maybe not at all.
That could be awkward.
It could, but the source stresses how important honesty is here. If you're struggling to take a medication, tell your doctor. They need to know so they can figure out why. Maybe it's side effects, maybe it's cost, maybe it's just complicated, and find a solution together. It's not about getting caught. It's about getting the right treatment.
Okay, this leads us perfectly into something the source really emphasizes: drug interactions. Taking multiple drugs seems to be a major risk factor.
Well, it's huge. The source basically says the risk goes up almost exponentially with each extra drug you add. More drugs, more chances for things to go wrong, either ADRs or drugs interfering with each other.
It gives some pretty scary real-world examples to hammer this home.
It does. really powerful ones.
Like the one with the blood thinner warfarin and an antibiotic?
Yes, warfarin and clarithromycin. This is a classic and frankly terrifying scenario. Imagine someone's on warfarin, right? They get bronchitis, go see a lung specialist. Maybe they forget to mention the warfarin, or the specialist doesn't ask specifically enough.
Right.
The specialist prescribes clarithromycin. Now, the source explains, clarithromycin stops the liver enzyme that normally breaks down warfarin.
So the warfarin level skyrockets.
Exactly. The blood gets way too thin. The example describes a severe nosebleed needing hospitalization, but it could easily have been a life-threatening internal bleed. And the source is crystal clear, completely avoidable.
If only the patient had mentioned the warfarin.
Or if the specialist had checked. But the source really puts the onus on the patient too. You have to tell every doctor, every healthcare provider about every single thing you're taking. Prescriptions, over-the-counter, supplements, everything.
Well, that's a big responsibility.
It's shared, but yes, your role as the central hub of information about your own meds is crucial.
Okay, what about the other example involving common heart failure drugs and ibuprofen? Seems harmless enough.
That's the scary part, right? Ibuprofen seems harmless. But this example is another stark warning, especially about long-term self-medication with OTCs. So picture someone with heart failure. They're likely on standard meds like an ACE inhibitor and a diuretic.
Okay.
Then they start taking high-dose ibuprofen, maybe for chronic arthritis pain, because, hey, it's over the counter. The source explains that NSAIDs like ibuprofen can reduce blood flow to the kidneys. Combine that effect with the ACE inhibitor and the diuretic, which also affect kidney function and fluid balance.
And it's too much for the kidneys.
Exactly. It can tip them into acute kidney failure. Now, often it's reversible if you stop the ibuprofen quickly, but it's a serious medical event and preventable.
So long-term OTC painkiller use needs caution.
Definitely. The source stresses talking to your doctor or pharmacist about chronic pain, looking at alternatives like paracetamol or maybe metamizole, which don't have that same impact on kidney blood flow. Don't just assume OTC equals safe for long-term use.
The kidneys keep coming up, don't they? With dose reductions, too.
Yes, because they're the main exit route for so many drugs. If your kidneys aren't working well, drugs that are normally cleared that way can build up to toxic levels.
Which drugs need dose adjustments?
The source lists several common ones: acecloprid for viruses, metformin, diabetes, lithium bipolar, methotrexate, arthritis, cancer. And it highlights a really dangerous situation.
What's that?
When different specialists prescribe these kinds of drugs without knowing what else the patient is taking. Particularly with methotrexate, the source notes this coordination failure has led to avoidable deaths. Again, it comes back to communication and having one person, often your primary doctor or pharmacist, overseeing everything.
Can even food mess things up? Food interaction?
Absolutely. The source mentions this too. Even healthy foods can sometimes cause problems with specific drugs. You don't need to go crazy, but it's worth knowing about major interactions.
Like what?
The examples given are tyramine-rich foods, aged cheeses, cured meats, stuff like that interacting badly with older antidepressants called MAO inhibitors. Also calcium from milk or juice interfering with the absorption of bisphosphonates for osteoporosis, and also thyroid hormone T4. Need to take those on an empty stomach away from calcium.
Good to know. So with all this complexity, all these risks, where should people go for reliable drug info? Presumably not the TV ads.
Definitely not the ads. The source is very clear. Avoid drug ads. They make unrealistic promises. Also be wary of random stuff you find online, forums, unverified sources.
So where to go?
For solid info, the source recommends proper textbooks by experts, scientific review articles, original research papers if you can access them, but crucially, it really emphasizes using your pharmacist.
They're a key resource.
Absolutely. Pharmacists are highly trained drug experts. Ask them questions. They can explain how to take things, potential interactions, side effects. They are hugely underutilized as advisors.
Okay, let's quickly touch on a few specific disease examples from the source, just to see these principles pop up again. Mental health depression, schizophrenia, the source says, finding the right drug often takes some trial and error.
Yes, it mentions that this kind of testing phase is pretty common. Because everyone's brain chemistry is different, you might need to try a couple of options. Adjust doses to find what works best for your specific symptoms with the fewest side effects.
And it highlights clozapine for schizophrenia.
It does. Calls it the most effective antipsychotic, and uniquely, notes that it actually prolongs life for patients and rarely causes those severe movement problems some older drugs do.
There's a catch.
Big catch. Significant risk, though, in a small percentage of people of a dangerous drop in white blood cells.
Hmm.
This means mandatory, regular blood tests. So it's a powerful example of a drug with huge benefits, but also serious risks that require careful management and monitoring. Risk versus benefit right there.
Right. And lithium for bipolar.
Also highlighted for its benefits, reducing hospital stays, and importantly, it's noted as non-addictive.
Okay, shifting to pain. We hammered NSAIDs and coxibs for their risks. What about metamils?
Right, metamizole. Good for severe pain, especially that internal cramping colic pain, and also for high fever. The source notes its main risk is rare, but potentially fatal. A granulocytosis, that same severe drop in white blood cells we mentioned with clozapine.
And its use varies.
Hugely between countries. The source points this out as a fascinating example of how different cultures weigh drug risks and benefits differently. What's standard in one place might be restricted elsewhere.
And opioids for pain. Addiction risk.
The source clarifies. When used appropriately under medical supervision for genuine severe pain, the risk of addiction is actually quite low. The high risk comes when opioids get into the brain very quickly, like IV injection, or with extremely potent ones like fentanyl used improperly.
Okay. Emergency severe allergies, anaphylaxis, EpiPens.
Yes, epinephrine autoinjectors. The source stresses these are potentially life-saving, especially because you can administer them yourself immediately. The key is speed.
Seconds matter.
Absolutely. Epinephrine works in seconds. That's crucial in anaphylaxis. Compare that to something like a glucocorticoid pill or injection, which takes hours to really kick in. You need that immediate action.
Cardiovascular stuff. We
Yeah.
mentioned the ABCD drug classes for blood pressure. Statins come up again.
Yes, statins. Mainstay for lowering cholesterol, preventing heart attacks, strokes. Highly beneficial, but the source reiterates the risks. Muscle pain with statins should never be ignored,
Why not?
because in rare cases, it can signal serious muscle breakdown that could damage the kidneys. Usually happens with high doses or drug interactions. Also reminds us about coxib heart risks and that tricky long half-life of amiodarone-making interactions, like with warfarin, a real challenge.
Diabetes. Big difference between type 1 and type 2 treatment.
Massive difference. For type 2, metformin is hailed as the gold standard oral drug. Effective, generally safe if you watch the contraindications, like kidney function, and crucially, it doesn't cause hypoglycemia, low blood sugar.
Unlike insulin.
Exactly. Insulin is essential for type 1 diabetes, life-saving, but it carries a constant life-threatening risk of causing hypoglycemia if the dose isn't perfectly matched to food, activity, everything. Very different risk profiles.
And glucocorticoids, cortisone.
Bit of a mixed reputation.
Historically, yeah. Older uses, high doses, long term. Led to serious issues. Ulcers, high blood pressure, weight gain, diabetes, weak bones, infections. A nasty list.
But it's better now.
The source explains that with modern versions like prednisolone and Smarter, use careful dose tailoring, monitoring, taking it in the morning like your body's natural rhythm, tapering off slowly. Doctors can often get the powerful anti-inflammatory benefits while minimizing those risks. Sometimes they add other meds, like stomach protectors, too. It loops back to NSAIDs being developed as non-steroidal alternatives, but, as we said, having their own significant long-term risks.
Finally, antibiotics. Key message.
Key message. They only work against bacteria. The source pushes for the term antibacterial drugs to be more accurate. Absolutely useless against viruses like colds or the flu.
And misuse is bad because drives resistance. Using them when not needed, or using broad-spectrum ones unnecessarily, helps bacteria evolve to beat them. MRSA is the scary example given. And the source hammers home. Vaccination is the #1 way to prevent many infectious diseases in the first place. Also mentions remdesivir for COVID as another repurposing example. So, okay, pulling all this together, everything we've dug into from these excerpts, understanding the names, how variable drug effects are, how they work, how they travel, the ADRs, the interactions.
It really makes you realize, doesn't it? Understanding this stuff isn't just like academic. It's fundamental to your own health, your safety. It empowers you to be part of the conversation about your care.
It absolutely does. And when you think about how complex these substances are, how much your individual factors matter, your age, your diet, other meds, and the real risks, even with things you buy off the shelf,
Yeah.
it kind of leads to a final thought, doesn't it?
Yeah.
For you listening right now,
Yeah.
given all this, what does your active role in making sure your drug therapy is safe and effective actually look like?
It's definitely more than just swallowing a pill when told. It's about being informed, asking questions, being a real partner in your own healthcare. Definitely something to think about.